Hello, I'm Ian Paul, and this is the second module in the series on mood disorders. It focuses on suicidality and self-harm, risk assessment, and safety measures for patients at risk for suicide. These are important considerations for any patient with a mood disorder, as well as several other psychiatric disorders. This module has 4 objectives. After finishing it, you should be able to describe the terminology used in the psychiatric description of suicide and self-harm, identify important epidemiological features of suicidality, explain the critical variables to assess a patient's risk of suicide, and identify and illustrate potential safety measures for patients at risk for suicide. Let's start by reviewing the psychiatric meaning of 4 terms that will be used throughout this module. The first term is suicidality. Suicidality refers to thoughts and/or actions related to a patient's risk of suicide. This can include everything from passive thoughts of death or self-harm to planning, rehearsing, or even attempting suicide. Next, it's important to distinguish between ideation and attempt. As you'll see, many people have suicidal thoughts, but only a subset of those individuals actively attempt to harm themselves. The term impulsivity refers to an individual's tendency to act on momentary thoughts, such as suicidality, without reflection. Finally, risk assessment refers to a medically informed assessment of an individual's risk of self-harm and suicide. However, it's important to remember that risk assessment is subjective. It's almost impossible to distinguish with certainty between patients who will or will not eventually attempt suicide. Nevertheless, risk assessment is a critical first step that informs a physician's therapeutic plan. At any age, suicide is one of the top 10 causes of death in the United States. During adolescence and early adulthood, it is the second leading cause of death, and even among middle school children, suicide is among the top 3 causes of death. Moreover, suicide rates have steadily risen by more than 25% over the past 2 decades. Clearly, suicide represents a major public health problem. In addition, it is important to recognize that each suicidal individual has a profound impact on multiple members of that person's family and social circle. The ripple effect of suicidality magnifies its damage exponentially. Women attempt suicide more often than men. However, men complete suicide attempts at a much higher rate than women, largely due to the fact that men tend to choose more lethal means of suicide, such as self-inflicted gunshot. In addition, the suicide rate among women peaks in middle age, while the rate in men increases steadily over the lifespan, reaching its peak among elderly men. In addition, regardless of gender, Native American and non-Hispanic Caucasians have much higher frequencies of suicide than do members of other racial and ethnic groups in the United States. Finally, consider this. Americans are 10 times more likely to have significant thoughts of committing suicide as to actually attempt suicide. In any given year, at least 10 million people give serious thought to taking their own life. It is somewhat comforting that only 1 million actually attempt suicide in a year. However, bear in mind that without treatment, suicidal thinking tends to be recurrent. That means while someone thinking of committing suicide may not do so in the next 12 months, the risk of suicide attempt increases with each year without treatment. While suicide is usually associated with depressive disorder, it's important to note that comorbid depressive disorders are only diagnosable in about half of suicide attempters. A quarter of suicide attempts are associated with thought disorders like schizophrenia. In addition, any disorder that increases impulsivity, including many bipolar and personality disorders, as well as substance use disorders, are major risks for suicidality. A good way to remember the risk factors for suicide is the SAD person's mnemonic. Male sex, age less than 19 or greater than 45, previous depression, previous suicide attempt, excessive substance use, loss of rational thought, separated or single, having an organized plan, having no social support, and finally illness, specifically physical illness. Finally, consider this. About 90% of suicide attempters saw a primary care physician, such as a family practitioner, internist, OBGYN, pediatrician, or emergency physician, in the 12 months prior to the attempt, and 70% saw a PCP in the last 30 days prior to their attempt. This means suicidality is not simply a mental health problem, it is a medical problem that most physicians will encounter during their normal practice. For that reason, screening for self-harm should be as much a normal part of a clinical encounter as obtaining vitals or routine lab work. When evaluating a patient's risk for suicide, first consider psychiatric comorbidities such as mood disorders, substance use, schizophrenia, and personality disorders, particularly those in cluster B such as borderline personality disorder, that display significant impulsivity. Personal and family history of suicide attempts or mental illness is also significant. Prior suicide attempts in particular are a huge red flag. Next, consider the patient's strengths and vulnerabilities, such as their coping skills and their ability to accurately assess reality. In the psychosocial realm, are there any acute or chronic stressors, such as a recent romantic breakup or low socioeconomic status? How strong is their social and family support network or their religious or spiritual affiliation? Finally, what is their current level of suicidality in terms of ideation, plans, and behaviors? When assessing suicidality in a patient, it's important to cover 5 major points: ideation, plan, means, intent, and support. As with other sensitive areas of medical questioning, it's good to open with a statement that indicates your questions are a routine part of your examination, much as you might when asking about sexual activity or substance abuse. Then start with simple questions about ideation, such as, have you ever thought that life wasn't worth living? Or, do you sometimes wish you could go to sleep and not wake up? If the answer is no, you can finish with a supportive statement such as, good, but if this does happen to you, I want you to know that you should reach out to me. Thoughts of self-harm are more common than most people think, and you shouldn't try to handle them without help. If the answer is yes, you should ask about the other 4 areas so that you can get the most complete picture possible of your patient's situation. A positive assessment of risk, even of a small risk of suicide, should move you and your patient into the development of a safety plan. One of the best evidence-based approaches covers 6 areas. First, help the patient identify warning signs such as bouts of sadness, agitation, or stressful situations. Next, discuss possible internal coping strategies such as distraction, meditation, or exercise. Similarly, discuss possible socialization strategies for distraction and support from family and friends. Fourth, work with the patient to identify family and social contacts to reach out to in a suicidal crisis situation. In addition, safety measures should always include specific information on professional and agency contacts such as therapists, emergency departments, and suicide and crisis resolution hotlines. Finally, safety measures should include explicit discussion of means restriction, such as locking up medications, relocating handguns away from ready access, up to and including hospitalization if necessary. A great resource for information on suicide risk and prevention can be found at the Suicide Prevention Resource Center. You should also be aware of the National Suicide Prevention Hotline. The FCC has approved the 3-digit 988 for use. However, check to see whether it's been activated in your area. Finally, the National Suicide Prevention Lifeline has a website with a lot of information and tools. A good review of suicide and the sad person's mnemonic can also be found at osmosis.org.